I'm so honored to be here, and I thank the organizers for giving me the opportunity to speak on managing heart failure in people with comorbidities with a view to optimizing guideline-directed medical therapy. There are several barriers to guideline-directed medical therapy implementation, and across jurisdictions, we see that therapies that are life-saving are underutilized, as these data from the IMPROVE and CHAMP cohorts demonstrate. Beta blockers, shown in orange, RAS inhibitors in blue, MRAs in green, and ARNIs in purple are underutilized among patients who are eligible and have no contraindications to these therapies. The reasons are myriad, starting from healthcare and policy factors related to access and pricing of pharmacotherapies, inadequate technologies to streamline data required to make decisions at the point of care, inaccessible specialty care, at the clinician level, knowledge gaps, uncertainty about generalizability of trial results, biased decision-making. We know that certain demographic groups are undertreated for heart failure, and very real concerns about contraindications, safety, and tolerability of these drugs. And at the patient level, there are issues related to education, insurance coverage, frailty and complex comorbidities, as well as preference and side effects that patients may experience. These guidelines, and Mike will present them, have shifted from a traditional sequential approach to optimizing therapies to the upfront initiation of our pillars of heart failure care that include ARNIs, or ACE inhibitors or ARBs, beta blockers, MRAs, and SGLT2 inhibitors. And for patients that don't tolerate them or are still symptomatic, potentially adding second-line therapies such as ivabradine, vericiguat, hydralazine nitrates, and digoxin. There have been recent trials that have been largely ineffective or minimally effective, and the arguments have been that the patients were too high risk to benefit from therapy. We certainly had the cardiac myosin activator go up for FDA approval this week, and it was declined approval on the basis of results that showed minimal risk reduction despite high event rates. And this plot that we show you here demonstrates really that on the x-axis, as the event rate increases, risk reduction also increases. So really, when you have high event rates, a high-risk population, among effective pharmacotherapies, you see a larger reduction in risk. Among pharmacotherapies that are less effective, you do not see this pattern. And so we see that the first-line agents that are preferred in our guidelines and guidelines across the world, there is really good justification for the use of those 4 pillars that I presented to you. There are some limitations to the uptake of these therapies, unfortunately, and blood pressure is one of them. Traditionally, we have advised to continue optimizing therapies and increasing dosages despite hypotension, as long as patients are not clearly symptomatic. But as some of these curves show, beyond a certain point, there is a relationship between renal function and blood pressure, and diuretic efficiency and blood pressure, such that there's a threshold below which both renal function declines and diuretic efficiency declines. And yes, I see what you mean, Dr. Flores, about not having a pointer. It makes it easier to demonstrate physiology. These curves also show a U-shaped relationship between blood pressure and the risk of dementia and death. And what you see on the y-axis is the risk of dementia, death, or both dementia and death. These data are based on individual patient meta-analyses of 7 prospective observational cohorts that were followed over time, with dementia determined by objective measures that the patients undertook during this follow-up period. The risk that you see is U-shaped. At a very low systolic blood pressure or very high systolic blood pressure, there is highest risk of both dementia and death. This risk is augmented The U-shaped relationships are augmented in older adults, as you see. So the first set of rows depict adults in the 60 to 75 year category, and the age groups increase as you go down to the lower rows, and you see that the U-shaped curve is actually accentuated in older adults. So something to keep in mind for older adults who might have low blood pressure at the point of care. Another consideration beyond blood pressure is disease stage. We all know the results of the LIFE trial that randomized 335 patients to a strategy of sacubitril valsartan or valsartan among those with advanced symptoms and low or reduced ejection fraction. And the trial demonstrated no significant benefit of ARNIs over ARBs in this cohort or in this trial for the primary composite endpoint of change in NT-proBNP. So admittedly a surrogate endpoint, but a definite risk in hyperkalemia seen in the ARNI group, 17% hyperkalemia versus 9% in the ARB group. So another group in which you might reconsider a strategy based on where the patient is at their disease stage. Another consideration is sex of the patient. This is a secondary analysis of the digoxin trial, which, as we know, did not reduce mortality overall, but did reduce heart failure hospitalizations. But it demonstrated a sex-treatment interaction. So treatment was effective in males, but not in females. In fact, females had a higher risk of death on digoxin, both unadjusted and adjusted for other baseline characteristics. So it gives us pause to consider the use of digoxin in females who might be at risk of digitoxicity. And then rhythm is a consideration. We know that ivabradine is recommended in patients with sinus rhythm, but it is associated with an increased risk of atrial fibrillation seen across trials. So in patients at risk of atrial fibrillation, you might reconsider ivabradine. Another aspect of rhythm assessment is that beta blocker treatment effect are attenuated in atrial fibrillation. This is an individual patient meta-analysis that you see in the bottom left panel. And across trials, beta blockers did not reduce risk for all-cause death in patients who had atrial fibrillation across the EF spectrum, so something to consider there. And of course, EF, and these are data from the GALACTIC trial showing that omecamtiv mecarbil, which had an overall 8% risk reduction for the composite of cardiovascular death or heart failure or hospitalization, was nominally effective in the higher range of the reduced EF spectrum and more effective at the very low range of the EF spectrum. So a practical approach to optimizing guideline-directed medical therapy when the blood pressure is low, consider the age of your patient and the impact on cognitive status. There's still a lot we do not know among patients with heart failure, what the thresholds for systolic and diastolic blood pressure should be. But we know from the STRONG-HF trial that was presented this year that titrating blood pressures sort of in the range of 95 systolic was safe. They did not up-titrate medical therapies below a systolic blood pressure of 95, which I know seems high for some of us who take care of these patients. Assess for symptoms and signs of hypoperfusion. Think about cognitive function as well when you do that. Address reversible causes of hypotension. Correct volume depletion or congestion, both of which could limit your cardiac output and cause hypotension. Deprescribe medications that lower the blood pressure without offering a clinical benefit. And then, of course, practical things like staggering your doses of RAS inhibitors and beta blockers because you don't want the peak effect to coincide causing hypotension. In patients with advanced heart failure, switch ARNIs to ACE or ARB if the patient tolerates it, keeping in mind there's no benefit to the ARNI and only risk at that point. Initiate second-line guideline-directed medical therapies, considering sex, rhythm, EF, and kidney function, and discontinue the 4 pillars only as a last resort after having referred your patient for advanced therapies. Another big limitation is concomitant kidney disease. This is our summary of all of the clinical trials across heart failure in the reduced EF range. and shows that most trials used an eGFR of 30 as a threshold for inclusion, and the median GFR was actually around 40 or higher in most trials. So in terms of up-titrating medical therapies, you might use 30 as a cutoff for most classes, keeping in mind that SGLT2 inhibitors were tested outside the heart failure population and the kidney disease population down to GFRs of 20 to 25. So you might consider up-titrating that class in the lower GFR range. Indeed, heart failure and chronic kidney disease are a double whammy. Among comorbidities in heart failure, CKD carries the highest population attributable risk for death, and yet is associated with the lowest uptake of therapies. The problem might be that the definition of kidney endpoints have varied across trials, and we are now working to create unified outcomes for kidney measures. But certainly it's hard to do a comparative effectiveness of the effect of certain heart failure drugs on kidney endpoints when the endpoints were defined in varied ways. And there are large knowledge gaps in stage 4 and 5 CKD. So in these patients, we don't know the effect of our therapies. In fact, we have some data from MRA trials that the treatment effect is attenuated at the very low end of the GFR spectrum. So certainly initiate, up-titrate down to a GFR of 25 to 30, but reconsider below that based on the current evidence. I just want to make a couple more points that our heart failure guideline-directed medical therapies have physiologic effects on kidney function, both through afferent vasoconstriction for some drugs, efferent vasodilation for some drugs, and changes in filtration fraction that vary across class. And because of a combination of these physiologic effects, it is normal to see an early acute drop in GFR with the initiation of these therapies. These should not give cause for concern because there's no association with adverse renal clinical endpoints. These graphs show on the left that among patients who are healthy, GFR decreases with time, as you can see in the green bar, and as you age. Among patients with heart failure, seen in the orange bar, or in the orange line, I should say, graph, there is an acute decline in GFR after a heart failure event, but that decline slows down over time. The decline is greatest among people with heart failure and concomitant diabetes, so these require urgent attention. The initiation of therapies for heart failure, as you can see on the right among patients with heart failure, results in an acute rapid decline in eGFR, but a change in slope, so that overall, over time, the eGFR slope declines at a slower rate. So good cause for us to continue therapies despite the temptation to stop when we see the creatinine rise. And I'll just quickly say that across trials of ACE inhibitors, ARBs, ARNIs, both cardiovascular outcomes and renal outcomes appear to improve. We know this across trials of DKD and chronic kidney disease, and the same holds true for MRAs and for SGLT2 inhibitors. We know that they improve cardiovascular endpoints in patients with heart failure, renal endpoints in patients with diabetes in particular, and for the SGLT2 inhibitors in particular, regardless of hypertension, heart failure, or diabetes, people with chronic kidney disease improve their kidney and cardiovascular endpoints when on SGLT2 inhibitors. And I haven't presented the DAPA-CKD or EMPA-kidney results, but they showed a benefit in these endpoints for people who had chronic kidney disease. So chronic kidney disease, older age, hypotension associated with some challenges in guideline-directed medical therapy optimization. We should all remember that the small TREAD-HF crossover trial in 51 patients demonstrated that when we withdraw therapies from people who benefited from them originally for HFrEF, After their EFs recover, we precipitate heart failure. And the endpoint of this trial was a surrogate endpoint, but nevertheless nicely demonstrated the point that we should persist with these therapies for as long as the patients can tolerate. So in summary, a practical approach to optimizing guideline-directed medical therapy: address reversible causes of low blood pressure or changes in your eGFR, keeping in mind that the early reduction in eGFR should not give us cause for concern. We must persist in these therapies. Keep in mind the age of the patient, consider cognitive function, correct volume depletion or congestion or other reversible causes of hypotension or kidney injury, de-prescribe unnecessary medications, persist with the evidence-based therapies of beta blockers, RAS inhibitors, MRAs, and SGLT2 inhibitors. Consider staggering or decreasing the doses of medication so that the peak effect doesn't coincide for the blood pressure lowering agents. Consider sex, rhythm, kidney function when you start second-line therapies, and discontinue your 4 pillars only as a last resort after referring for advanced therapies. Thank you very much for the opportunity.